right. Well, welcome everyone, and thank you so much for being here on a Friday. I'm really excited to talk about this topic. This is something that has felt really close to my heart, and working with clients and also having a couple of different family members who have sustained traumatic brain injuries. And I know that's true for a lot of folks. So really excited to be here with you all. I'm going to go ahead and share some slides and just kind of give everyone a sense of what this presentation will look like. Let's see here. I want this to be big. Okay. Can everyone see that okay?
Yes.
Great. Okay, so my name is Savannah Stidhams. I'm a full-time therapist here with Self Space. And as you all probably have read, this is a training about just an introduction for counseling traumatic brain injury survivors. This is a pretty under-discussed area, but something that feels really important to start creating some space around. So to kind of give you a sense of what we'll be covering today, we're going to start out with a little bit of an introduction. I'll share a little bit about kind of my background and what's bringing me here to leading this training. And then we'll do a little bit of a meditation to kind of get grounded here with each other. I'll provide some background about traumatic brain injury and some of the kind of terminology there, so we can all kind of get familiar. And then we'll talk a little bit about clinical assessment and some interventions that I've learned about and have found to be really helpful in my work with traumatic brain injury survivors. And I'd love to make this kind of interactive, and so please feel free if you have questions or just have a thought that you want to chime in with while I'm talking, to interrupt me at any point or pop something in the chat. And if I don't see you, hopefully someone can unmute and just let me know that someone is trying to get my attention or chime in. And then at the end of this, we can hopefully just come together for a little bit of a collaborative discussion around what feels important or what questions kind of came up over the course of the training today. So a little bit of background about me. I did my undergraduate in psychology and sociocultural anthropology at the University of Washington, spent a couple years in community mental health after that. And then I went into my master's program at Bastyr University. And it was actually during my internship there with Self Space that I really started to delve into the traumatic brain injury space, because I had a client who was part of the low-cost therapy program that came in with a severe traumatic brain injury. And I'll be talking about her a little bit more throughout this presentation. She's really generously given me permission to do so, and has really changed my life and my outlook on this topic. So since then, I've been collaborating on a number of different research projects around this. I had a professor at Bastyr who's a neuropsychologist, and we've kind of connected on a number of different case study presentations and manuscripts together in this domain, covering things like dynamic assessment and feminist therapy approaches for working with traumatic brain injury survivors. So that's kind of my background. I feel really fortunate to have been able to acquire a good amount of knowledge through that process, but also think it's really important to just name that I am someone who in general has pretty neurotypical brain functioning, and that's a real privilege. And so I'm leading this training and approaching working with this population in general with a tremendous amount of humility and an understanding that this really is a learning process. And that's very much still ongoing for me as well. So I'm really just here to share the information that I've been fortunate enough to acquire about this. Yeah. Okay. Well, I'd love to kind of just start with a meditation then. Wanting to just kind of acknowledge that I think everyone here is probably in the mental health field, and it's a really interesting time to be a part of that. I know that we're all probably navigating some undercurrents of our own emotional experiences as well, given the current state of sociopolitical and global affairs. And so just wanting to acknowledge that many of us are probably between things in our busy lives, and really just wanted to take some time to intentionally settle in here, and be really present with each other and with ourselves for this training. So yeah, I'll just kind of invite you to find a comfortable position, whatever that looks like for you today. You're welcome to turn your camera off or leave it on. You're welcome to close your eyes or just let your gaze be soft. And I'll just invite you to take 2 or 3 grounding breaths here at your own pace. You might liken each breath to an anchor that could help you land in the here and the now. You can just continue to let your breath flow naturally, noticing where the breath goes as it enters your body and where it goes as it leaves your body. Now I'll invite you to gently draw your attention to your head. Without delving into any thoughts, you might just notice how your head feels today. Is there a part of your head that calls your attention the most? Is there a heaviness or a lightness? Is there a warmth or a coolness? Just notice whatever you can notice about the physical sensations within your head. You might notice tense muscles, maybe in your forehead, your neck, your jaw. And if you can, just see what it might be like to soften some of this tension. As we settle into this shared space together, notice what it's like for you to be here. Perhaps considering your committed presence during this training as a gift that you're giving yourself. And if you're willing, you might think about your values and your intentions, what brought you here today. You might replay in your mind and your body what you are like when you are the most compassionate, authentic version of yourself. How do you act? How do you carry yourself? What kind of energy do you exude? How might you participate in co-creating a memorable experience for us here? I'll just invite you to align with that intention for yourself and commit to being your fullest and most aligned self throughout this training and this discussion. If your mind drifts, that's completely natural. You might just offer your thoughts your love and come back to the open awareness of the physical sensations of your head. Checking in, noticing if they've changed over time. Be mindful of any tension that might have come back into the muscles of your forehead, your neck, or your jaw. An option here to soften them gently again. Before closing this practice, take a few more seconds here to breathe and connect with whatever sensations or intentions felt important to you in this practice today. Continuing to just let any tension melt away. Whenever you're ready, you might bring a bit of movement to your hands and feet and slowly start to open your eyes and rejoin me. Right. Well, thank you all for doing that with me. I definitely needed that today. So really appreciate you all being here again and taking that extra time to be intentional. Yeah, I guess we can kind of just dive in from there. I see some more people have joined us, so welcome, whatever point you came in at. I gave an overview a little bit ago, but we're just heading into some discussion around the background of traumatic brain injury and just kind of talking about some terminology that might be important to know and yeah, just getting familiar with that. So I'll throw up a couple of definitions of what traumatic brain injury is, and I won't read them off, but you can kind of get the sense that this is a pretty broad description. Traumatic brain injuries can happen in all sorts of different ways and can look extremely different depending on the nature of how it occurs and what areas of the brain are actually affected by the impact of the brain injury. So just kind of sharing those. And I'd love to get a sense actually here, I'll kind of invite some participation. Who here has actually had a traumatic brain injury themselves, if you're comfortable sharing, or knows someone who's had a traumatic brain injury, or works with a client, can just raise your hands or, yeah. Oh, wow, okay. Yeah, so definitely a good number of us. I just kind of wanted to go over some of the prevalence because I think this is a pretty under-discussed area. I know that most clinical and counseling master's programs don't necessarily heavily incorporate discussing this into the curriculum. There's a lot of different areas to cover and it can often kind of get swept to the wayside. But the statistic here is just kind of citing that it's actually quite common. 2.5 million people per year is not a small number. And you can see that 80,000 of those are not just dealing with that initial injury, but also the lifelong impact of that injury. And there's a lot of nuances there too for many folks. There might not be a permanent disability status present, but there can be lots of other ways that can show up and affect people's lives. I would love to kind of open up a conversation about where folks have heard about traumatic brain injury the most, through the media, or kind of what the common representations of that look like in other people's experiences. I know one of the areas that I kind of had previously thought about it the most was definitely in kind of the veteran military population. But yeah, I'm curious if that tracks, or what have you all kind of heard?
Also with athletics, I feel like it comes
Yeah,
up a lot of things around athletics.
for sure. Yeah, football, like CT and football has been a big kind of discussion point lately. Yeah.
My mind goes to like traumatic brain injuries from car accidents, and just I have a relative who worked for like a nonprofit for people with intellectual and developmental disabilities, and a lot of people ended up in that facility because of like a car accident with a very severe traumatic brain injury. So like a very specific presentation of it.
Totally. Yeah. Yeah, absolutely. Yeah. So kind of combat, car accidents, and sports are some really common ways that we hear about traumatic brain injury. Yeah. So I just wanted to kind of share some additional statistics, to kind of give like a bigger scope as well. And I was kind of surprised about some of these. It turns out that for the geriatric population and for kiddos, like pediatrics, falls are actually the #1 way that traumatic brain injuries occur, which makes a lot of sense. And I know a lot of us probably see kids or see some older folks. And it's not something that, you would necessarily be ultra aware of, without seeing these statistics. Interestingly, firearm related suicide and assaults are the #1 leading cause of traumatic brain injury. Also, however, the most common traumatic brain injuries that actually result in death. And so that might also be kind of an underrepresented area of discussion around traumatic brain injury. And I thought it was also important to mention that domestic violence and intimate partner violence is another really common area that we see traumatic brain injuries happening, and not a lot of discussion around those. And part of that is a lot of domestic violence and IPV survivors don't necessarily feel comfortable going to hospitals or actually getting treated for those injuries always. So there's a lot of underreporting for some really understandable reasons. And Aaron, car accidents are one of the leading causes of traumatic brain injuries as well. But I just thought it was interesting because I think the representation around sports in particular has been so prolific, but that's actually a very small, very, very minor fraction of the actual total number of traumatic brain injuries that happen. So it's just kind of interesting sometimes how media portrayals can influence sort of what's available in our brains around what we think about these different topics. I also thought it was important to mention just the political relevance of traumatic brain injury. I had mentioned IPV and DV, but we're also living in a social context where things like police brutality, institutional abuse, hate crimes, etc., are happening and can really impact the experience of traumatic brain injuries when there's these other layers of trauma surrounding them that have to do with larger sociopolitical systems and power dynamics. And I think kind of given our current global context, it's likely that many of us who are interested in working with asylum seekers or refugees might also be seeing some traumatic brain injuries as a result of people fleeing from war zones and needing a lot of just support around the emotional impact of that in conjunction with treating the traumatic brain injury itself. And just kind of a little caveat, hypoxic ischemic brain injury, or HIBI, is not considered a traumatic injury, but it's essentially a brain injury that happens when the brain is deprived of oxygen for a prolonged period of time. And because we are living in the midst of an opioid epidemic, and many people who see clients who struggle with substance misuse might be encountering people who have had their brains deprived of oxygen, maybe 1, 2, 3, 4, even 5 times now that Narcan is available, and people are frequently overdosing and coming back after that. So just something to kind of be aware of in there, just the kind of chronicness and repetition that can happen around that. And same with strangulation and IPV and DV settings. So just kind of thinking about how that might factor into why it could be challenging for someone to stop using substances when their brain functioning could also be compromised by factors like that, or why it might feel really difficult for someone who's in a dangerous relationship situation to leave when they actually might not have access to their brain functioning in the way that they previously did. So just kind of noting that and wanting to give a really clear kind of big picture overview of, yeah, the politics involved in some of that too. When I think about traumatic brain injury, kind of the first place my mind went as like a newer clinician trying to understand like what that meant was like, how is it rated? What does the medical side of that look like? What does it mean when my clients bring me information that they've been told by their doctors that like I might not really understand, and how much are they really understanding of that? And I'll pause here before I kind of switch gears. Does anyone have any questions, and am I making sense so far? Cool. Okay. Awesome. Please let me know if any pop up. I wanted to share kind of the most common medical assessment that I've stumbled across that's sort of used to evaluate the severity of a traumatic brain injury. Essentially, they're divided into 3 sort of tiers: mild, moderate, and severe. And usually that assessment happens like pretty quickly after the injury is sustained, oftentimes by just a paramedic or a first responder, or the first doctor that a client would see. And the grading scale is based off of eye movement, verbal, and motor functioning. So it's pretty safe to assume that if someone loses consciousness for more than 30 minutes, they likely have a moderate to severe brain injury because they're not going to be able to be responsive with their eyes, their verbal abilities, or their motor skills right away. And on this scale, which you can check out in the slides that will be sent out later, you can see that the higher the score, the more severe the brain injury, essentially. And clients will often know the severity of their brain injury and be able to kind of tell you that. So this is kind of what that's based off of. It's just kind of a loose rating scale of what happened initially at the time of the accident. And it can be a little bit confusing because it's helpful to know the general gist of what occurred and what grade the traumatic brain injury was given, but it doesn't give you a lot of information about what that might mean for your client's functioning. And a lot of the time, especially with mild traumatic brain injuries, clients or patients will be told that they will not have, can expect to not have lingering cognitive impact effects. And that can be largely because it can be very hard to detect mild traumatic brain injuries. There are some biomarkers in the blood that there's a lot of technology kind of being developed around how to track and how to identify earlier. But unfortunately, a lot of the time when people receive a mild traumatic brain injury, they may be told that the impact of that will be less than it actually is on their subsequent functionality. So that's a kind of big thing to consider when someone says, I was told I had a mild concussion or a mild TBI, or they're often left with the impression that nothing is going to change for them following that after 6 weeks. And that's usually true, but often not the case as well. So just something to kind of think about there. The other part of the assessment to consider when you're sort of moving through discussing an accident or the way that a brain injury was sustained with your client would be sort of their personal context and interactions with the medical industry in general. So kind of getting a sense for how they felt they were treated by their doctor, what kinds of interventions happened at the time, what kinds of interventions were available through their insurance. So just really trying to kind of get a picture of what their process was. Like, did they just go to the hospital and kind of get sent away? Or were they in the hospital for a while and then had the chance to go to a neurorehabilitation clinic and get occupational therapy? And understanding the kind of layers there can help you get a little bit of a better picture about what other supports or tools they may already have, and what their experience might have been like after that. And chances are, if someone has a moderate or a severe traumatic brain injury, they have probably saw a lot of doctors, and they've probably had quite a bit of interaction with the medical community. And a lot of the time, those interactions are focused on functionality and kind of just restoring, getting people back to independent living, or getting them back to a place where they feel like they can resume their life activities in a way that feels more sustainable than immediately after their injury. So that's kind of just a little bit of background that's maybe helpful to know. When I think about our role as the counselor, it's important to understand that, but our assessment can be kind of conceptualized in two pieces. One of them is around understanding the client's executive functioning and kind of where they are at with that right now, and what all that kind of medical terminology actually means for what their day-to-day life looks like and how it may have changed. And then the second part is around self-concept, and we'll get into that in a little bit. But something that has kind of come up in my research with the professor that I mentioned earlier, Dr. Caitlin Zequine, is the utility of dynamic assessment strategies for traumatic brain injury survivors. So a lot of the time, we can, stumble across standardized measures that can be really helpful to give clients to screen for different things. But with traumatic brain injury, I've really found, and I think there's a lot of support for the use of dynamic assessments instead, which kind of involves the process of asking your clients specific questions and then asking for their feedback around the relevance of those questions and how important they are to your client, and what other areas you might be missing, or maybe want to focus more on. So it's sort of like a collaborative, extended, and really intentional assessment process without the use of a standardized tool. Well, you can also do it with a standardized tool if you ask for feedback, but in general, you're not just administering it in the same way you would a standardized tool. So thinking about executive functioning, this is sort of what I would consider to be step one of the process in a lot of cases, especially if you're working with someone who has a moderate to severe traumatic brain injury, because this can really help you understand how you might set up your sessions to be most accessible for your client. And something that I learned and that Dr. Zequine had really encouraged me to think about was the fact that many folks who've had a lot of experiences in the medical system and have received a lot of social messaging about what their differences in brain functioning might mean about them, might have a lot of shame about their executive functioning and might be trying to mask and really kind of keeping things together in your initial sessions. So really taking the time to slow down and check in and really let your client know that, like, this is not a space where we need to be perfect. Like, this is a safe space where you can really be yourself, and how can I help co-create that for you? Like, what do we need to do to make this feel like a space where you can just come here and be you, and we can really just sit together in that. So one of the pieces that can be really helpful working through asking questions about executive functioning is asking your client to kind of describe to you just like what's feeling hard for them, or what are they noticing feels different for them following their traumatic brain injury. My client that I've been working on this case study with was really generous and shared a podcast episode with me that I'll share in the handout that'll accompany this training, that sort of breaks down executive functioning into 6 major domains. So it involves things like starting tasks, organization, memory, all these different components that you can kind of use to assess what each individual's personal executive functioning kind of looks like. And a really helpful example that my client described to me was that someone with neurotypical brain functioning would typically write down on a to-do list, like clean off their desk, right? Like there's a bunch of stuff on your desk, you're going to clean it off. That's one task. But actually for her, that task was broken up into 6 or 7 different separate tasks. So really thinking about the way that that process might not be automated depending on someone's executive functioning. It might actually be taking everything off the desk, figuring out where each item goes in the house, managing distractions that can come up while moving items to different surfaces, gathering cleaning supplies for that surface, cleaning off the surface, putting the things back on the surface. It's actually really challenging depending on the way in which someone's executive functioning may have been impacted by their injury. So really slowing down and giving your client the space to kind of walk you through what those experiences are like for them. And maybe those pieces aren't something that all clients will struggle with. Maybe it's more like memory, and maybe, you know, writing down their to-do list at the end of the day in their notebook isn't going to work for them anymore because their short-term memory has been impaired and they need more measurements in place to help them track throughout the day. But to give kind of an example of what using this type of assessment to structure the sessions could look like is kind of after checking in with your client, really working together to collaborate on a structure. So my client sort of made the request that we start each session with a 10-minute check-in where we, you know, maybe use the feelings wheel to kind of talk about like what emotions are up in the beginning of the session, check in on things like sleep, hydration, nutrition, other factors that become exponentially more important when someone is trying to recover from a brain injury. And then there's kind of a planning period that's usually built into the middle of the session. And because my client had been in different forms of occupational therapy, she already had some tools that worked really well for her. So if your clients already have things that are really doing the job, that's kind of a great time to really welcome those into the work together and really use that strengths-based approach of acknowledging your client as a whole person who probably has some really great stuff that's already available to them. And then what I have personally found working with traumatic brain injury survivors is that usually the planning needs to happen and the organization needs to happen before the emotional content becomes available. There can be a lot of noise that gets created if the client is feeling like they're struggling to know what the rest of their day or their week looks like, and they really need some help actually just grounding and checking in. And so it's important to be kind of monitoring anxiety level, kind of checking for overstimulation, and really making sure you're in a grounded space before getting into emotional content if you are working with someone who really struggles in some of those executive functioning domains and needs that checkpoint. So that's just one kind of way that can look. I'm wondering if anyone has any questions or thoughts or just curiosities about this part specifically.
Yes, Savannah, I do.
Yeah.
How have you noticed some of that can sound similar, sounds possibly similar to like just someone who has an attention deficit disorder. So how would you kind of navigate the difference between, I mean, obviously, maybe not obviously, but it sounds like you're expecting the client to know that they have a traumatic brain injury and that you're working with that actively. But I'm curious if you know, if you can kind of sense the difference between just attention deficit and like this executive functioning issue regarding brain injury.
Yeah, that's a great question. There is a lot of overlap because executive functioning is something that's affected across all forms of neurodivergence, including autism and ADHD. There's certainly some overlap in the way that you might approach and folks with TBI and folks who are neurodivergent for other reasons. My sense is that the biggest difference is the fact that someone who has sustained a traumatic brain injury was typically not born with that traumatic brain injury. It is true that sometimes there can be in vitro traumatic brain injuries that happen and people are born with that injury present. But what I have kind of heard reflected from folks with traumatic brain injury that I have interacted with is that there's actually a lot of grief and anger and kind of reconciliation around having sustained such a traumatic injury that has so drastically altered their functioning. So it's not necessarily that the executive functioning components that you're working on and that you're seeing with them will be so different. It might be that the emotional layers behind that are different. And certainly in a big part of the neurodivergent community, and specifically within the autistic community, there's sort of a identity claiming component of that. Like folks are identifying as neurodivergent, that is a part of who they are, that is how they're born, and oftentimes can be a real source of community and pride. And it's not that folks who have experienced traumatic brain injury cannot also find sources of pride and a sense of community within that. But typically, they're often conceptualizing traumatic brain injury as something that has happened to them, oftentimes in a very traumatic way. And there's a lot of grief work that can surround that and the impact of that.
That was really interesting and helpful. Thank you.
Absolutely. Thanks for that question. Yeah. I'm also realizing I'm talking so much, I don't know if I'll be able to get to all of my slides today. So I will do my best to maybe zoom through the next section a little bit and get to some of the clinical implications. Thank you all for bearing with me. Kind of the second part to talk about, and kind of descriptions explaining these graphs are included in the handout, so don't worry. But there's a big self-concept component, and this is sort of what Nate's question was leading to, is that when someone sustains a traumatic brain injury, there's usually a pre-injury identity and this sense of a post-injury identity for a lot of folks. This can be due to a lot of different reasons. Oftentimes there are lots of changes to, like we just talked about, executive functioning, but also the social groups and communities they may have been involved with, the degree of social acceptance that they might be experiencing. It can be a really jarring shift if someone has really had a substantial impact where their executive functioning and their day-to-day life looks really different. A lot of folks who were previously employed may no longer be able to work. Like there's some really huge stuff in there. And depending on identity intersections, there can be a lot of increases in marginalization, things like that to navigate through. So essentially what these models are saying, the one on the right that was published by Douglas et al. Is essentially talking about the way that self-concept is sort of broken down into who I am and how I feel about myself components. And the interesting thing that this article found was that social connectedness interacted with every single element of the model. So they were really pointing to the fact that social connection and friendship formation is really critical to self-concept for traumatic brain injury survivors in particular. And this is supported by the other model on the left by Levac and colleagues, who actually did a study where they interviewed really extensively almost 50 different traumatic brain injury survivors and sort of qualitatively pulled out the things that felt the most important about self-concept for those survivors. And this has been really well supported in the literature. And essentially what they found was that having a sense of self-coherence, having a valued place in the world, and feeling validated, respected, and accepted by others were the most critical parts of self-concept for traumatic brain injury survivors. So this was very exciting to read. They were essentially really encouraging people to do their own research using these domains, develop a measure using these domains. And so Dr. Zecoin and I kind of pulled these things out and used these factor structures to create a dynamic assessment tool that I utilized with my client in our case study together. And kind of going back to earlier, remembering that dynamic assessment is where you're sort of asking questions based on these factor structures, but also checking in with the client and asking, like, is this important to you? Like, is the way that I'm framing this actually relevant to your experience? Does this make sense to your context? What else are we missing? And through that process, oh yeah, you can look at the dynamic assessment tool right there if you want to scan that QR code. But through that process, my client and I found it really helpful because it allowed us to pull out a couple of different domains that felt really, really important to her. And those additional domains were parenting and the reconciliation of having different layered marginalized identities. Previously, my client was very much passing as neurotypical, and a lot of the other identities that may relate to historically underserved populations were not necessarily visible. And following that injury, which is true for many people who survive moderate to severe traumatic brain injuries, she could no longer present as neurotypical and was really interacting with society in a different way. And that's something that has been pretty sparsely discussed in the literature and is something that our feminist therapy approach with her was really helpful for unpacking. So that's just kind of an example of how moving through a dynamic assessment process with a client can really create the space to further define like what you're actually working on in therapy with them. And what's actually important to them, rather than columns or identities or components being sort of assigned to their experience. They're getting the chance to identify what it is that has changed for them, what it is that feels important about the way that their self-concept has been altered, if that's the case, following their traumatic brain injury. So you can kind of see there those new factor domains and some of the ways that we addressed that in the case study that I'm referencing. And this might look really different for another client, but I think it's also important to name that a theory that I think is pretty solid is that because so much of the research in traumatic brain injury has been sports and military population focused, there's a real underrepresentation of female or femme identifying traumatic brain injury survivors, and therefore almost no research on how parenting as a neurodivergent woman or femme presenting person is experienced in this population. So I think that may have been a part of why that hadn't come out earlier and might be a more common experience than one would think. So I'll just kind of move through to the next slide here, but want to kind of open it up again if any questions came up about the self-concept part.
I have a question, I suppose.
Yeah.
I would be curious to hear your thoughts around what about those qualities become just so much more important for someone with a traumatic brain injury? Because I know I'm noticing I'm resonating with like, oh yeah, I need all those things too. And I'm wondering if, I don't know, the relationship with it is different.
Yeah, I think that's a really good point, Erin. Like I would assume that probably a lot of those domains are really central to self-concept for anyone, regardless of whether they're a traumatic brain injury survivor. Um, I think where maybe some distinctions come out is because undergoing a traumatic brain injury is such a foundationally shifting event, and there can be an experience of so much change and loss of friendship and community. That's kind of a common hallmark of what leads to anxiety and depression in traumatic brain injury survivors. Um, those things can become even more important or feel amplified in their importance. One thing that's been kind of reflected a lot in my work so far with this population is the sense of being like, really maybe resonant with a lot of independence before, and really turning towards kind of collaboration and community following their injury, and therefore more value and importance being placed on community relationships and those dynamics compared to before their injury, if that makes sense. Yeah. And I think with the parenting one in particular, that one feels especially important, at least for my client, because I don't know if any of you guys have tried to navigate like PTA or PTSA platforms or the systems involved with those, but they're really complicated. There's like 10 different forums sometimes, and so many different steps to scheduling and events. Like school and academic systems are really complicated, I think, even for neurotypical parents supporting their kids. And so kind of factoring in a traumatic brain injury parenting and kind of all the moral judgment that gets wrapped up in that and navigating those systems can feel extra important, and be really challenging in a lot of ways. Thanks for that question. Yeah, I kind of just wanted to cover some typical interventions that usually happen when someone has a traumatic brain injury. And this is more for people who maybe have moderate to severe traumatic brain injuries. But there's usually an immediate hospitalization, a surgery, and then depending on insurance and accessibility factors, a lot of folks will have inpatient and then outpatient neurorehabilitation, or just one or the other, depending on their injury. And then again, depending on insurance and accessibility, occupational therapy. And all of these things are really geared towards, like I was mentioning earlier, kind of restoring functionality. But what are they all missing? Definitely a mental health component. Something that's sort of been resounding in most of the experiences that I've come across is that there really is a focus on just getting people back to being able to go through their daily tasks and live in an independent way, or get through their workday, maybe, if there's someone who's just navigating a more mild instance where they're not needing quite as many steps as others. And the aftermath and the kind of grief and real shifts that can happen on a mental health level afterwards are oftentimes really neglected. And I think a trap that it seems like maybe a lot of really, really well-intentioned providers fall into is getting into the mindset of like, well, what are you talking about? You're walking so well now, and you can cook on your own again. You're doing great. Like, don't worry about the fact that, you're not feeling as connected to your community and you're feeling very anxious and overstimulated all the time. So there can be kind of like a toxic positivity thing that comes around in conjunction with the functionality, or as functionality increases, survivors feel like their mental health should also be increasing, and that part of them is not really being addressed a lot of the time. And that, I'm sure, is not due to any intentional factors on the medical provider's parts. It's just that's how they're orienting, that's how they're trained. They're there to kind of help restore functionality. So a big part of another piece that can be important is maybe establishing some collaboration with those providers and starting to bridge that gap as clinicians. So for the intervention part of this all, I sort of view dynamic assessment as something that can very much be a part of the healing. For a lot of traumatic brain injury survivors, if they're coming to therapy, you know, a couple years after their injury, for example, you might be the first person who has really taken the time to understand what it might be like to be them, and to really understand their executive functioning, to really express curiosity and empathy towards the mental health concerns that they're facing. So really slowing down that process and just being with that person and understanding their experience as it relates to their traumatic brain injury can be so powerful in itself. So I really view that as an assessment and an intervention in one. I work through a feminist lens, which I think can be really useful for this population because there's so much social system interconnection happening for people who are navigating disability status, changes in executive functioning, while living in a pretty neurotypically and ableist-oriented society. And just finding ways to offer self-compassion and maybe change the basis of comparison there can be really helpful. Values work can be really helpful. What a lot of folks find is that their core values and the fundamental things that they care about have not necessarily changed that much since their brain injury. So even though it can feel for a lot of folks in many ways like their life is completely different, there can be a lot of grounding in coming back to the understanding that, like, actually probably a lot of those values are still true. And if they can kind of shift towards evaluating themselves based on the degree to which they are aligning or moving towards their values instead of the degree to which they're mapping onto neurotypical social standards, that can be a really powerful shift. Social support and resourcing is also huge because of the role of social connection for a lot of traumatic brain injury survivors. In the handout that I'll share, there'll be a lot of links to different organizations that have support groups, podcasts, just lots of different organizations that do a lot to sort of try to connect that community. And I think for a lot of folks, just knowing that they're not alone in what they're facing, and maybe getting the chance to hear from people who have also sustained traumatic brain injuries and are navigating some of the same things can be really helpful. Dr. Zecoin is much more of an expert than me on this part, but metacognition is really, I think, going to be pretty pivotal and something that I'm hoping to do more research on with her as well. Metacognition is essentially, for those of you who are familiar with ACT, it's a lot like cognitive diffusion. So it's sort of this awareness of like being able to step back and work with the client to identify how their brain works from a more objective perspective. So kind of like, my brain works in this way, and therefore, like, these are the things that I need to support my brain. And like, just having that degree of removal and the ability to articulate the way one's brain works, and then what would naturally help that brain kind of succeed in the things that are wanting to happen, can be really useful. There can be a lot less attachment to guilt and shame around some of those things when metacognition is involved. So that that's powerful. Brain bucks has been something that has been a pretty big hit in terms of talking about energy expenditure and kind of like rationing brain energy every day. So kind of like we talk about spoons with people with chronic illness, the idea that like maybe someone who struggles with chronic illness starts out with a few less energy spoons than other folks who don't each day, and then kind of has to ration those out in the way that feels most meaningful to them. You might talk about brain bucks with someone who has a traumatic brain injury and really work with them to understand like what's costing you the most brain bucks right now? What gives you brain bucks? How can we keep that bank account as even as possible? So there's like some work around balancing. And I think it can be really helpful sometimes just to ask those questions, because there might be certain tasks that like aren't actually that important, that are taking a ton of brain bucks. And there's not even awareness around that. I think we can all kind of relate to that. So just kind of helping your clients work through that lens and using metaphors and kind of fun visuals can be a really cool way to broach those topics. And lastly, I really love using meditation and breath work with clients who have experienced traumatic brain injury. This is really well supported by the literature as well around fatigue and overstimulation in this population. And I think, again, this is one of those things that's really well supported across a lot of different populations, but is something that I maybe use a little more actively when working with folks with traumatic brain injuries, because, you know, as you get to know a client, you can maybe catch on when it seems like there's some overstimulation happening in session. And if you already have those tools and you're working on building those together, using those in-session moments to pause and engage with some of that can be really good modeling for skills that can carry on outside of that and help people feel more in control and congruent throughout their day. I wanted to kind of throw up a couple of new treatment modalities for TBI. Dr. Zequin and I presented our dynamic assessment poster at the Traumatic Brain Injury Conference, the 13th Annual Traumatic Brain Injury Conference in Washington, D.C. last summer. And a lot of the presentations there were around the use of psychedelic-assisted therapy, transcranial magnetic stimulation, and then probiotics and lithium as kind of like supplements or medications that seem like there are some really good benefits around. So I'm certainly not an expert in any of these domains, but those presentations were pretty compelling and made me just kind of want to share these as potential avenues to explore if you do have a client who's already kind of orienting or curious about psychedelic assisted therapy, for example, or maybe wants to understand like what some biological supports could look like for them. So just thought I would share that. And there's a decent amount of research out there about these things as well that would be available if you're curious. And yeah, this I think is just some clinical takeaways of what we've already talked about. So I won't go over all of those just for the sake of time. I want to make sure we can have a discussion. But I will be sending out this slide deck. And then this is a QR code to a handout. This includes some academic articles, some resources and tools that you might want to use with some of these clients. And then training options. There's a ton of free webinars and trainings through organizations like CBERT. So those are available. And then I also included a people to know section on there because I have just found consultation when working with this population to be so incredibly valuable, just because that training isn't necessarily built into our clinical and counseling master's programs. Collaborating with a neuropsychologist or someone who really has an understanding of both the kind of counseling and clinical framework, but also the sort of like more neuropsychology medical side of things is incredibly helpful. And I did list Dr. Z Coin on there. She is by far the most transformational resource that I've engaged with so far around any of this. So I've included her email there if anyone else is maybe interested in consulting with her. And then I've also included some just big names in the field that have a ton of really great research on all of these things. So we'll send this out as a PDF later too, but feel free to scan that as well. And I think I'm going to go ahead and stop sharing here and just open our last 28 minutes here for some discussion. Yeah, I think now would be a great time for any questions. But I also want to make a lot of room just if people are having thoughts or things that have been brought up for them throughout this training. Please just share whatever feels authentic.
I have a lot of thoughts coming up. But I guess I'm thinking of one of my clients now, and I'm wondering, Savannah, how you might handle someone who has not experienced a traumatic brain injury, but is kind of gearing up for a scarier invasive brain surgery and doesn't know where that might leave them. Yeah, I'm thinking in your experience, like what would feel important for you to share with them, or how would you want to show up with them?
Yeah, that's such a good question, Lily. Yeah, that's maybe another type of like traumatic brain injury that isn't talked about quite as much either, is like surgery and operations in that way. I think where my mind might go for a client presenting with that would probably be around resourcing and social support and kind of seeing about getting them involved in communities post-op that might be able to help them through that recovery process. But I would also be kind of thinking about the degree to which their doctor is sharing information about like what that post-op period might look like and how to kind of translate like the medical dialogue that your client might be ingesting into something that makes more sense for them or that might be more useful for your work together. So I would maybe consider consulting with the doctor or kind of working with kind of in a systems way with the client around trying to help get them as much agency and to feel as empowered as possible with like knowledge about how things could look, while also holding, of course, like a lot of fear and maybe some grief around the fact that maybe some things are out of their control or can't fully be known before the surgery. That's so challenging. And if anyone has thoughts besides me about that, please like feel free. Yes.
I just want to add, maybe giving them a space to really share what they're truly feeling about that surgery and that. I mean, it sounds like you've started that, but they probably in all of their medical appointments are just having to get like the medical basics and not be able to really process their emotions. So that might be also something to consider.
I had a related curiosity because I'm also thinking about clients that seem to have a lot of overlap. For instance, a client with a stroke that was like, experienced due to an external pressure. So and then there's some overlap there. And also a client that I'm seeing that is experiencing varying medical issues that to me seem to possibly be dementia, but there's some I guess like unrecognized or unresolved medical issues with their symptoms. But
Mm.
I just notice when there's issues with communication, memory, issues with there's a cognitive impairment that I have to try to figure out, okay, what can we work on verbally and what can probably become its own challenge. If I'm overemphasizing, work that's very much in a verbal space as opposed to maybe a somatic space. So I wonder, when you feel like with some clients, you might need to shift towards more, so nonverbal focused work and what that looks like.
Mm. Mm. That's a really good point and a really good question. Yeah. And I'm imagining, yeah, you're just probably holding a lot as a therapist, noticing and wondering about those things. And I'm sure your client is probably experiencing a lot of emotions related to that as well, if they're picking up on some of the differences in their own system.
Yeah,
Um,
exactly. Like you brought up earlier, of just like the sense of like grief, like you said, just the sense of grief and loss of old me versus, who I am now. Yeah.
yeah, totally. Yeah, and so, and I'm sure it sounds like you're already doing this, but part of that might be that grief processing of like working through the felt sense of that and what's that like, and where is safety and what are those kind of anchor points. But I think when it comes to kind of vacillating between like verbal processing versus more kind of somatic work or other modalities, um, I would maybe like inquire about what your signals are from them if it seems like they're becoming dysregulated or maybe feeling overstimulated or struggling verbally. I wonder about like contracting with them and talking about that beforehand when you're not noticing that as much, and
Mhm.
thinking through with them like what might be some helpful strategies in those moments that would feel really good for their system um, to do with you. And it might be some like throwing spaghetti at the wall and seeing what sticks too, if they're also not familiar with what might feel best for them.
Yeah, yeah, yeah. And this is like, yeah, a new space. I'm still exploring, so this is really helpful to think about. And I think one of the things that I'm like really cautious about is, as I bring awareness to this, it might also trigger like a sense of like, oh, I'm this is, because I'm just so less than what I used to be. That's sort of the message that
Mm.
I hear of just like, oh, this is another way that I'm not living up to the expectations that I have for myself, when I'm noticing like that, in our conversation and that I'm, losing them a little bit. They're not tracking what we're talking about. Something's happening, and I bring awareness to it. It seems to trigger some amount of shame.
Mm-hmm. Yeah, that's so hard. It's so
Yeah.
challenging because when you're working with someone who has that level of shame, like even if you are using really strengths-based language and like you are coming from a very compassionate space, like their system is maybe still going to have some of those activations. So that might be part of the work itself, is like processing some of that live in the moment, which I'm sure you're probably already doing. But yeah, I think that's a great point too, of like what are the gentlest ways to bring some of that up. And maybe there are some ways of like switching gears that can happen that don't involve directly calling out like what you're noticing. Yeah, maybe like gentle transitions. Yeah, Dr. Zequin, do you have any thoughts about that part?
Um, I'm wondering if maybe you could sort of like put it on yourself, like, oh gosh, I've lost you, I'm not making sense, kind of thing, to kind of take that pressure off, and then just gently be like, let me try again, or let me try a different strategy for explaining this, kind of like take the blame for them not tracking, just as like a gentle way, and then it'll hopefully become a safer space in that way to talk about their own faults as well, or their own challenges that they have.
Mm.
Okay, yeah, that's great to think about. Thank you.
This is not as much the therapist in me, but more just the human in me that has had interactions, kind of like what you're talking about, Mohammed.
Yeah.
And what I've noticed for myself is if I'm able to say like, hey, I really want to understand what you're saying, but I'm having a hard time doing that, or however you want to phrase it. I've noticed that really just making it clear that like, I am here, I want to know what's happening for you. And I understand there's a wall between us, but I really want to break through it. I really want to know. I think there's something about that that has worked well for me in the past. Again, not in the therapist chair, but just out in the wild. And I'm also thinking sometimes I shift in those situations to make it less about like what I'm saying and more about how I might be making the person feel. Because I found that as neurocognitive decline might advance, like even if my people aren't remembering what I'm saying or aren't picking up on it, there is some kind of memory within them of how I've made them feel that has felt, from my perception, really helpful in situations like that.
Yeah, thanks, Lily. That makes me just also take a step back and think about how similar that, vantage point, that sort of like direction, outlook matches how I work with traumatized clients that, emotional dysregulation also can impair their communication and what they're receiving from me, or communicating to me in a similar way to like neurological and cognitive impairments. So at least there's some overlap there that I'm noticing. Yeah. I can take some of those strengths and carry them over. Yeah.
Mm.
You're making me think about Dr. Terry Sheldon, who works with a lot of people with degenerative disorders and dementia. And he talks a lot about how if our role as a therapist isn't necessarily to organize the client, but to get that shared understanding and that I feel you, the feeling felt experience. And he'll ask a lot, if he's feeling lost, like he'll ask the client, do you feel like I'm understanding you? Like, and he'll kind of almost put the question back on them to gauge, like, are they feeling understood by me in this moment? If you're picking up on, I don't think I'm understanding. And then you kind of can get back on the client's page, because often if you're not, they might feel that too. And then you're kind of back on the same page immediately with, oh, we're not getting each other, but we want to, let's figure it out. And I always like that, because sometimes I've been surprised asking that when the client's like, yeah, you are. And I'm like, oh, okay. What, tell me more, how are you feeling? What's it like that I'm understanding you, that we're understanding you? And then you're kind of off and running. But I don't know. I found that helpful, Mohammed, when I'm in that moment too, of like, am I following you? Are we on the same page? And I just had a comment. I just feel like I'm so amazed, Savannah, like, the idea of a client even coming in to work in this space with the awareness of their injury and the impact on their life. I kind of, Lily, with you, just noticing in my personal life, people that I know that have had traumatic brain injuries, there's such a resistance to acknowledging the impact on anything.
Mm-hmm.
And, the shame you mentioned, Mohammed, is so, I think, big about acknowledging that there's an impact on their identity or their relationships or their functioning. And so I've seen people muscle through when, just the support you're talking about offering, Savannah, is so beautiful, and the grief work of acknowledging I am impacted kind of on every level you've discussed, on every level of identity and relational and functioning. It's just such a big step for someone. And I'm just so impressed that people come in doing that work already at such a place of acknowledgement. Just wow. Yeah, I just was feeling a ton of respect for clients that are already there. So.
Yeah, absolutely. Yeah, the client that I was mentioning had, sustained an injury over a decade prior. And just thinking about kind of retroactively processing like the accumulation of those years of experiences and what that means is huge. And I felt so much admiration too for those clients, because the level of self-awareness and the willingness to be vulnerable and maybe do work that would feel logistically easier to just kind of like put under the rug and muscle through. It's really amazing. Yeah.
Yeah, and I've worked a lot with patients in neuropsych assessment who've, had a brain injury, and we do recommend therapy often, but like that bridge is missing, right? Like, how do they schedule the appointment when they're having all these cognitive demands? How do they find a therapist? And then the therapist's not having enough training, it can sometimes feel like a burden to the patient. Like, I don't want to explain my injury to someone, or
Mhm.
all these medical appointments I've already had where I've, maybe been dismissed or told like, doesn't matter that my emotions are there because I'm walking again or talking again. It can really all add to it. So I think anything we can do, like Savannah's doing, to really bridge that gap is so helpful. And that's what I wanted to ask, like, is there, what else can we do to bridge that gap, from, the neuropsychology side to the therapy side?
Yeah, I think that's such a great question, and something that like I'm still very much exploring. I've spoken to a lot of medical providers, and it really feels like, and I think this has been your experience too, Dr. Zecoin, that like there's a desire there, like there's a want on both sides to bridge the gap. But I think both parties, like the medical field and the counseling and clinical field, are feeling a little confused or lost in like where that bridge is or who starts to build it how. So one of the things that I've been thinking a lot about is developing those relationships. And Rachel has been so helpful in starting to create some connections with Self Space and neurorehabilitation centers or specialists who work in those domains, so there can be more crosstalk. Because I speculate that if a provider like a neuropsychologist or a medical doctor really knew and trusted the quality of like counseling care at a certain organization for that population and was really advocating for that, rather than just maybe handing like a list of referrals without saying much, there might be some differences that start to happen just in how long that conversation goes and what's presented to the client, in terms of the appeal of seeking therapy. One of the other things that I've noticed and that my clients have reflected to me is sometimes, especially for like a moderate or a severe TBI, it can take a couple years following the injury for the client to be ready to do the emotional work. Even if those things are there, the first year after a really traumatic brain injury is kind of just the reparation of the actual brain, really, really just physically healing. And then, from what I have been told, it feels like there's another year oftentimes after that, even or more, where self-awareness is starting to be reintegrated. And it may not be until that point where they're ready to engage with counseling care. So I think I've been thinking and curious about like, yeah, what does it look like? Where do we meet those folks if they're 3 years after their injury? And maybe that would be a good time. How do we connect? And I keep coming back to those community connections, and really wondering about just like creating more of an environment where counselors can feel empowered to seek out the right information so they can put their services out there accurately and those people can see them. And just inviting more of it into our field, because it feels like there's just a really big lack of education around that, for most counselors, including myself before all of this. So, yeah. I also think if maybe when counselors are working with folks with traumatic brain injuries, if there was more outreach, obtaining neuropsychological assessments from doctors and doing more of that crosstalk that way, I wonder if more collaborative care would happen in that sense as well. Yeah, I wonder if anyone else has thoughts about like increasing communication.
I think think your client was a member of like some TBI support groups or something like that.
Yeah.
And I was, those groups would be a place where both counselors and neuropsychologists could come and just share information about like each of our roles or things like that, and like offer some free information sessions or things like that as a support, and just to help them better understand what therapy is for, and how to connect, kind of thing.
I love that. I maybe hadn't thought about going to the support groups because I was thinking maybe they were like closed, but I bet even if they were, if a counselor who was clearly wanting to share information requested to come at the beginning or at the end or sit in, that just seems like such a great, and I hadn't thought of that before.
Yeah, and I mean, even offering things that are, not therapy itself, but like a stress management info or some relaxation techniques or something like that, that it's like you'd be providing a service within the context of the support group, and then
Oh,
also being there if they did want to connect further. So
that's such a good idea. Yeah, and I had actually met with my client a bit earlier, and something that she had wanted me to share is actually in the handout, and it's called the UW. Let me actually pull it up. It's like the UW. Let's see. The UW Traumatic Brain Injury Model System. And on that website, there are like a bunch of different like talks and kind of initiatives that are happening at a community level locally all of the time. And yeah, it just goes to show there's a lot, maybe more resources that not everyone is familiar with that are happening, where we could maybe do some more crosstalk and sitting in at different events and things like that. Yeah. And there's some handouts on there too, that I was combing through that might be helpful for you guys to take a look at. There's just some really digestible information around like each domain, like fatigue and TBI, or like depression and anxiety and TBI, and like some really tangible clinical interventions sort of listed with some background in just really digestible ways. So yeah, make sure to check that one out. I'll pop it in the chat right now too. All right. Yeah. Does anyone have a last question or a last thought?
Yeah, hi, can you hear me?
Yeah.
Awesome. Hi, my name's Sophia. I'm just a current graduate student. And so thank you so much for this presentation, because like you mentioned at the very beginning, like this is not something that is taught within my program. And it's something that we really have to go seek out on our own. So this was like really new information to me. And I just really appreciate you taking the time and presenting this in such a digestible manner. I would love to share this with my peers if that's possible. But I also had a question. At the beginning, you were talking about how with your current client, she does some occupational therapy work and how you implement that into your sessions with her. And I just wasn't exactly sure what that looked like. Is it like occupational therapy exercises that you're doing during counseling session? I just haven't heard that relationship before in therapy.
That's such a great question. Yeah, I'm so glad you're here, by the way, Sophia. And yeah, so my current client did occupational therapy for a number of years following her injury. She's no longer actively in that form of therapy, but she still uses a lot of the different tools that she gained through that experience, and really cites it as like incredibly valuable for her healing process, really important for her. And What that kind of looks like is she has a lot of different systems, and I think this is pretty common for folks who go through occupational therapy. For example, she has like a planner, and similar to a lot of different apps for folks with neurodivergence, there's like stickers and lots of different kind of color coding and really specific systems that she uses to sort of track her weekly events and her goals, and kind of like make little brain bucks charts now in there and really organize her brain so she's not holding quite as much in her head and trying to track things, and has a place to sort of look as a reference for all of that. And that planner is like a pretty complex system that I think was actually specifically tailored to her, and created by her occupational therapist. And I think that's how she still gets those notebooks. So really important. A lot of her meditation and breathwork strategies also have come from occupational therapy. So that's something I kind of checked in with her about. And she had relayed that she learned some strategies, and we can kind of call upon those a lot of the time in session. And there's a couple other just sort of like semantic tools that she uses, and ways of thinking and conceptualizing her cognitive abilities that have language that's sort of tied to her occupational therapy experience. So I think that can look really different across different people depending on who they saw and, you know, what exactly happened in their context. But just asking her about that and calling in like all of her pre-existing tools has been really, really helpful. And I will say, I think that this particular client has has a really unusually high degree of like self-led initiative around those things. So to be honest, I haven't had to do a ton of like pulling that out. It's just been present and part of her systems. But yeah, I love that question. I think that's so important to consider.
Awesome. Thank you so much for sharing.
Of course. Great. Well, yeah, I know we're kind of down to our last couple minutes. It's been just really lovely to be here with all of you today, and thank you so much for your curiosity and your attention. As I cram so much into our hour and a half, it's just really revitalizing to get to connect in community around this really special topic. And I'm also available if anyone ever wants to talk about this, or, you know, has questions or just wants to chat. Please feel free to connect with me anytime. And like I mentioned before, Dr. Zecoin is another really, really helpful resource in our community around this. So yeah. Okay. Well, thank you all so much. Again, feel free to reach out if anything comes up, and I hope that you all have a lovely weekend.
Savannah.
Thanks.
Thank you.
Thank you.
So
Thank
much.
you.
Thank you.
Take good care, you guys.
Thank you.